Endoparasitic infection. Nematodes, roundworms, whipworms. So you find them until 12 weeks older. Infection by transplacental through milk and ingestion of larvae or the eggs. Highly zoonotic. Treat all in contact animals. Nursing young. So whenever you have young puppies coming to you, repeat treatment 2 to 3 weeks up to 12 weeks. Older, repeat treatment. First time you give and repeat after 2 to 3 weeks because they are swallowed and then comes to the GA tract, and therefore you can do it after 3 weeks again. So make it a point to do every 2 to 3 weeks up to 12 weeks in young dogs. Older dogs, deworm them and deworm them after 2 to 3 weeks again. So these are all the normal eggs, Ancylostoma, Toxocara, and Trichusa vulpes you see under the microscope. You always make it a point, all practitioners, you should have a simple microscope at least in your practice. So you should make it a point when you take temperature, the same thermometer can be rolled on to the glass slide with a bit of water or saline, and you see into the microscope. Supposing you see the eggs, sometimes you see the hookworm larva, the clients will get so much satisfied about your diagnosis. And most important thing, you should know how to treat them with a dose. So I just find, I'm not telling about all practitioners. Many practitioners do not mind about what to choose and how to treat. Parental pomade, dogs and cat, 5 to 10 milligram per kg body weight. It's okay in pregnancy. It's okay to give in nursing young puppies. Is okay to give. Fenbendazole, 50 milligram per kg for 3 days. Okay in pregnancy and nursing young ones. Praziquantel, you should not give them in less than 4 weeks old dogs or cats. Many of us, I see when they come to me as a referral, I find their card. We find them giving left central praziquantel for any age. So you should not give less than 4 weeks. Praziquantel and parental pomade not less than 4 weeks old or less than 1.5 pounds. Praziquantel, parental, febental. Nowadays we get a lot of these combination drugs. Most of the pharmaceutical companies come with this one. Not in less than 3 weeks old and less than 2 pounds, not to do with this drug, and not in pregnancy. Ivermectin, parental pomade, prevents heartworm. Of course, we don't have heartworm problem, so we need not bother about testing for heartworms in our country. But wherever you have heartworm, like in Kerala, we need to find out whether you got ivermectin. Heartworm before giving ivermectin. So ivermectin not less than 6 weeks. Then milbemycin oxime, okay. Ivermectin dose 200 milligram per kg body weight. Repeat 2 weeks later. Okay. So of course in colis they don't have to give. You can't give ivermectin because it's a recessive gene responsible for ivermectin crossing the blood-brain barrier. Next is coccidiosis. So usually, Isospora, Cryptosporidium are the main organism which cause coccidiosis. Rare disease, clinical signs, hemorrhagic diarrhea. Here you have, large bowel diarrhea. That is like raspberry jam or like a honey colored, small quantity, tenesmus. All these typical signs will be there. And if you find, do a fecal examination, you can find the coccidial spores. So diagnosis, fecal flotation and smear. Treatment, sulfamethoxazine, 50 milligram per kg, SID once daily for 10 days, or potentiated sulfa, trimethoprim sulfadiazine, 15 to 30 milligram per kg body weight, once daily for 5 days. Remember, when you're using trimethoprim sulfadiazine, it leads on to keratoconjunctivitis sicca. Use solution for treating dry eye. So that eye drop should be used continuously while treating with potentiated sulfas. Giardiasis can affect both dogs and cats. Prevalent in kennel dogs. Giardiasis should be suspected in all cases of parvo after coming out of the disease. You'll have to screen them for giardiasis. Clinical signs, chronic diarrhea. So this is characterized as soft cow patty consistency. That is like small small put doesn't shatter, doesn't sticks onto the ground. This sort of consistency. It has steatorrhea, malabsorption, and weight loss. Diagnosis: fecal flotation. ELISA is available now. direct smear, and treatment is fenbendazole 50 milligram per kg body weight, SID once daily for 3 days, or metronidazole 25 milligram per 3 kg BID for 5 days. Either metronidazole or fenbendazole. Fenbendazole better choice than metronidazole. Small intestinal bacterial overgrowth. Overgrowth of bacterial microflora in the proximal small intestines occurs secondary to stasis, mostly due to obstruction, ileus. So you can suspect after parvoviral, you can suspect small intestinal bacterial overgrowth, ileus, because any inflammatory disease there will be motility will be less. So ileus, inflammatory bowel disease, exocrine pancreatic insufficiency. In all these conditions, you have small intestinal bacterial overgrowth. Occurs secondary to defects in local immunity. Small intestinal aerobic bacteria changes in the anaerobic population. They consume the nutrients, degrade the bile acids, and the degraded bile acids damage the mucosa, leading to malabsorption and diarrhea. This is the pathogenesis of SIBO. So clinical signs, mostly German Shepherds are commonly affected. In German Shepherd, they're called antibiotic responsive diarrhea, okay? ARD. So they are affected. Cats, maybe they are affected, still documentation is required to say that this, cats are highly susceptible to SIBO. So weight loss, intermittent vomiting, and a small bowel diarrhea is a classical sign of SIBO. So you should always keep in mind what is small bowel diarrhea. Voluminous, frequency less, watery. These are all no tenesmus. All these things are not there in case of small bowel diarrhea. Diagnose, rule out other causes. Low B12 and high folate levels. So you know that this bacteria, consume cyanocobalamin. So you have low B12 and very high folate levels because they produce folate. So high folate and low cobalamin is diagnostic of SIBO. Breath hydrogen test we are not doing anywhere. It is a test which is done for researchers. Nowadays they don't do anywhere. Culture of duodenal juice, again very cumbersome, very costly. Preferred practices abroad is there. I don't think any lab in India is doing culture of duodenal juice. Intestinal permeability test, again we don't do intestinal permeability test. Histopathology, of course, when you have chronic diarrhea not responding to antibiotics, you learn to go in for histopathology. Antibiotics, doxycycline, metronidazole are drug of choice. But only problem with doxycycline is, one thing is doxycycline for long term, it causes severe esophagitis and, causes severe erosion of the stomach mucosa. Apart from that, resistance development is much more in doxycycline. So metronidazole can be a good drug of choice for SIBO. B12 supplements because they are consumed, diet low fat and easily digestible carbohydrate. Intestinal obstruction. So this is again a very commonly seen day-to-day practice. You find intestinal obstruction. There is structural obstruction like foreign body or intussusception. Functional obstruction like paralytic ileus, when there is some other problem, when there is no motility, you can have paralytic ileus. It can be acute or chronic. It can be partial or complete, simple or strangulated. So anyway, you can get this obstructions. So what is the pathogenesis of that? Once there is a foreign body, there's going to be ischemic bowel wall, bacterial toxins, there's going to be a clostridial overgrowth producing bacterial toxins. There's going to be more secretion of fluids because of the enterocytes, and they cause severe vomiting, and that causes dehydration, hypokalemia, acid-base derangements, death from, because of peritonitis, toxemia, and death can be because of severe hypovolemia and acid-base problem, or due to peritonitis, toxemia, and death. There's a two-way attack of pathogenesis whenever there's going to be a solved intestinal obstruction. Clinical findings: upper small intestinal obstruction, severe vomiting will be there. Distal small intestinal obstruction signs are less severe. Intermittent vomiting with fetid smell, putrefied fetid smell. suggests that it's a distal small intestinal obstruction. Valvulus, there's going to be peritoneal fluid accumulation, because in valvulus, there's going to be leakage of fluid. So if you see the X-ray, you'll find free gas and fluid accumulation in the peritoneal cavity. It's appreciable in ultrasound. Peritonitis can lead on to septicemia. Physical findings, there's going to be a severe dehydration, and you will be in shock, and you'll be in pain when you try to palpate the abdomen. Palpation of foreign body during physical finding. Increased small intestinal wall thickening, how you saw in IBD. So neoplasia, then sausage-shaped intussusception. These are all the things when you can palpate in the intestines when you have neoplasia or intussuscepted mass or increased wall thickening. There can be intestinal obstruction. Diagnosis, history, physical examination, oral cavity for linear foreign bodies, palpation for other foreign bodies, and intussusception. Hypochloremia, hypokalemia because of severe vomition. Radiography will be highly suggestive of foreign body, and it can be suggestive of peritonitis. Ultrasound is excellent for intussusception, foreign bodies, and treatment is surgery and antibiotics. Exocrine pancreatic insufficiency. Deficiency of pancreatic enzymes results in maldigestion and reduced absorption. Malabsorption and maldigestion are different. Maldigestion and reduced absorption are different. So etiology, idiopathic acinar cell atrophy. It can be due to viral disease or immune-mediated disease, toxemia or ischemia of the pancreas. All these things can cause exocrine pancreatic insufficiency. Or it can be chronic pancreatitis or recurrent pancreatitis or pancreatic neoplasia or flukes. Migrating flukes can cause obstruction in the pancreatic duct. Pathophysiology of exocrine pancreatic insufficiency. There is maldigestion and malabsorption. Bacterial overgrowth. Maldigestion is more than malabsorption. Bacterial overgrowth will be there. That you find out from folate and cyanocobalamin assay. Compromised digestive function. So it's signalment, increased incidence in GST, less than 2 years. Signs usually find polyphagia, weight loss, voluminous stools. I told you, malodorous, voluminous stools, steatorrhea, pica, very, very important, pica, coprophagia, fecus eating. You would have come across a lot of histories in your practice, coprophagic. It can be a behavioral problem or it can be exocrine pancreatic insufficiency. Borborygmus, increased sounds in the intestines, and flatulence, increased flatulence in the abdomen. Signalment, history, clinical signs, CBC, biochemistry, urine analysis, glucose, ALT, cholesterol, all these things have to be seen to get a glimpse of exocrine pancreatic insufficiency. There are lesser sensitive than main. TLI is the main test, gold standard for diagnosing exocrine pancreatic insufficiency. Trypsin-like immunoreactivity. Low vitamin B12 and high folate level in assay of vitamin cyanocobalamin folate assay is suggestive of exocrine pancreatic insufficiency. Biopsy, of course, can be really helpful to find out exocrine pancreatic insufficiency. Enzyme replacement is excellent treatment option for exocrine pancreatic insufficiency. Dietary modification, vitamin supplementation with A, K, and E, antibiotics for bacterial overgrowth should be given. Malabsorption. History, rectal examination, fecal cytology. So whenever you find no giardia or no parasites, then you should find there's going to be large bowel or small bowel problem. With narrow down to small bowel problem, where there's going to be voluminous stools, frequency is less, watery consistency, then you do CBC and ultrasound and other biochemistry tests, rule out polysystemic disease. Then you have either maldigestion or malabsorption. Then do serum trypsin-like immunoreactivity. If you have low trypsin immunoreactivity, then it is maldigestion. If a serum TLI tests are normal, then it is malabsorption. Malabsorption, if you want to further, confirm cyanocobalamin folate assay. Okay, so ultrasound, X-ray, endoscopy, feeding trial, laparotomy, or other diagnostic techniques to find out malabsorption. So it's it's classified as pre-mucosal defect, exocrine pancreatic insufficiency, and SIBO can cause malabsorption. Mucosal defect, IBD, infectious cause, food allergy, neoplasia, short bowel syndrome, they all are mucosal defects. Post-mucosal defect, congenital, acquired, lymphangiectasia, obstruction to the lymphatics. This all can cause malabsorption. So this is what I told you about, how to go about the diagnostic evaluation. History examination, rule out giardia and external helminthic parasites. Then zero in large bowel or small bowel. Small bowel, do CBC and other tests to rule out polysystemic disease, either maldigestion or malabsorption. If it is you do trypsin TLI, and if it is low, it is maldigestion. If it is normal, it is malabsorption. If it is malabsorption, do serum cobalamin and serum folate assay. So this again, we have already seen this cyanocobalamin folate absorption. So site where cobalamin is absorbed, site where folate absorption is given for you to understand where it is absorbed, which part of the intestine is taking care of the folate and which is taking care of cyanocobalamin. Based on that, you can evaluate different problems. Mainly, this test is to do SIBO and malabsorption. Other diagnostics are abdominal ultrasound, radiograph, rule out neoplasia, foreign body interception, contrast measurement for ruling out motility disorders, the eliminating diet trial, endoscopy, biopsy, duodenal juice and culture, they are of academic interest. Again, breath hydrogen test is not done. Occult blood can be done. Newer tests which are available in humans, chromium labeled albumin test for protein losing enteropathy. Fecal ELISA alpha proteinase inhibitor again an excellent test for this newer disease, and dual sugar absorption test, intestinal permeability, lactulose and rhamnose. They're all not practiced in day-to-day practice. They're all done in research and they are done in referral hospitals. Other causes of malabsorption, short bowel syndrome, where you do surgery and you have short bowel, chronic partial obstruction, then intestinal neoplasias, then small intestinal ulcers. All these things can cause malabsorption. Protein losing enteropathy. So protein losing enteropathy is very carefully, you should rule out protein losing nephropathy and hepatic causes. Hypoglobulinemia, hypoalbuminemia, both that's called pan-hypoproteinemia. Your protein be less, whereas in hepatic disease, your globulins be high. So your total protein will be normal. So in case of protein losing enteropathy, it will be classically both globulin and albumin will be less. You have ascites, you have edema, you have hypercoagulable state, thrombosis, all these things you will find in protein losing enteropathy. It can be because of ulcerative disease, can be because of inflammatory bowel disease, can be because of severe neoplasia infiltrating the mucosa, infection, lymphatic obstruction, that's called lymphangiectasia. Diagnosis is chromium labeled aluminum test. Again, not done because radioactive substance. Fecal alpha-1 proteinase inhibitor test is available in human, it can be tried. Those fat and starch staining, X-ray film, all these things were done yesteryears. Now it's not done. Plasma turbidity test, they are all not done at present. So what are the different causes of protein losing enteropathy? Lymphangiotasia, the lymph duct obstruction, infectious causes like paro and salmonella, they can go in for protein-losing enteropathies. Structural causes like intussusception, neoplasia like lymphomas, inflammatory diseases like IBDs, and endoparasitism, especially giardia or acrostomiasis, and gastrointestinal hemorrhage leading on to hepatic encephalopathy, neoplasia, and ulcerations. Next is the most important disease in small animal medicine, inflammatory bowel disease. This is purely a large bowel problem. Most common cause of chronic malabsorption, idiopathic IBD in dogs and cats. Common histopathological features. You have a lot of histopathological changes in the large intestines. The name based on types of infiltrate can be lymphocytic, plasmacytic. This is very, very common. Eosinophilic, inflammatory bowel disease or granulomatous enteritis. The etiology, it can be hypersensitive to various antigens. It can be a parasite. It can be a bacterial problem. It can be a diet. It can be drugs. Nobody has got any documentary evidence which causes IBD. There is what is known as there is an immunological deficiency in the mucosa which causes inflammatory bowel disease, and they have been able to document inflammatory mediators in all IBD diseases. So clinical signs: diarrhea, weight loss, steatorrhea, vomiting, borborygmus, flatus, halitosis, anorexia, loss of litter training in cats. These are all significant inflammatory bowel disease. The most important clinical signs, I told you, large bowel problem. There's going to be, tenesmus. There's going to be hematochezia. There's going to be small quantity, frequently. That is the reason the cat repeatedly visits litter, doesn't pass the motion. So these are all clinical signs observed in inflammatory bowel disease. Diagnosis: histopathology, feeding trial, blood biochemistry, cobalamin folate assay, blood hydrogen test. Treatment: hypoallergenic diet is the best treatment available for IBDs, which are to start with, they should start on hypoallergenic diet. Glucocorticoids, antibiotics, azathioprine as an alternative to glucocorticoids. Of course, we need to give vitamins and easily digestible carbohydrate and omega fatty acids for anti-inflammatory effect. Food allergy. Next is food allergy. Again, is a very common, subject for small animal practitioners. Food allergy, and you have, a lot of companies making a huge money in selling hypoallergenic diet. So any food can be potentially antigenic to a dog or cat. Most common, food allergy in dogs is milk, chicken, beef, wheat. These are the most common allergens for dogs. In cats, fish. So anything can be potentially antigenic. Antigen can cross the mucosal surface and induce IgE and IgA mediated food allergy disease. Inflammatory mediators are released, and there's going to be severe inflammation. That is what is seen as signs. Proteins are prevented to access the immune system by the process of digestion. Gradual exposure prevents IgE and IgG development. So whenever we start giving food to dogs and cats, so the owners tend to give all types of food. So that sort of exposure should not be there for them to develop IgG and IgA. They should, for 6 months, they should stick on to some food, and later on they can introduce food. Injured mucosa, IBD, SIBO, viral parasitic diseases, and defect in local immunity can be responsible for development of hypersensitivity. It is two-way about. Either hypersensitivity can lead on to IBD and SIBO, or IBD, SIBO, and other disease can lead on to hypersensitivity. In either way, it's true. So food sensitivity, adverse reaction to food, categorized into food intolerance and food hypersensitivity reactions. So food intolerance, dietary indiscretion, reaction to dyes added in the food, additives, can occur on first exposure to food, any food substances, non-immunological. Whereas food allergic disease is hypersensitivity to ingested antigen, and it's got an immunological basis. IgA and IgE mediated is food allergy. Food intolerance is different. Food allergy is different. And more of the food allergy, apart from food intolerance, you have only GI systems. In food hypersensitivity, you have GI system plus dermatological disease. That is another classical, information by which you can find out whether food intolerance or food allergen. Common allergens: beef, milk, fish, cat, lamb, wheat, chicken. Clinical signs: vomiting, diarrhea, weight loss, flatulence, anorexia, colitis, dermatological lesions. As I told you, most of the signs are non-specific. Okay. Diagnosis: serology testing, not available in our country. Intradermal testing, you can borrow from human side and do intradermal testing. Gastroscopic testing we don't do in our country. Intestinal permeability test we are not doing. Dietary trial, of course. So you give a hypoallergic diet for about 6 weeks, and then gradually start adding different food and find out what it is reacting to. That is hypoallergic food feeding trial. So hypoallergic diet or sacrifice protein source, antihistamines, omega fatty acid, and glucocorticoids are the main treatment protocols for treating food allergy or food hypersensitivity. Intestinal fungal disease, histoplasmosis, phycomycosis, aspergillus, and diagnosis by cytology. Treatment is antifungals like itraconazole. It's a very rare disease, but still, if you find fungal spores in the fecal examination, then you can go in for anti-fungal treatment. So, with regard to SI, small intestinal disease, what is the take-home message? You have acute diarrhea, chronic diarrhea. We need to differentiate them. And chronic diarrhea, you have small bowel diarrhea and large bowel diarrhea. Then you'll have to differentiate maldigestion and malabsorption. I told you how. Then you have to think about exocrine pancreatic insufficiency, small intestinal bacterial overgrowth, or for German shepherds, antibiotic responsive diarrhea, inflammatory bowel disease, obstructive disease like intussusception or tumors or foreign bodies, helminthic disease, viral disease, bacterial disease, fungal disease. And we have seen about fluid therapy. Main fluid therapy consists of colloids and crystalloids. You have to give potassium whenever required. Glucose you have to give after testing for glucose. If less than 40 milligram, you have to give. Otherwise, glucose in a critically ill patient produces more problems than good. So whenever you want to give in enteritis, look for glucose. Less than 40 milligram, give glucose. Okay. Then motility modifiers, antibiotics, 4-quadrant antibiotics. I told you about cephalosporins, potential amoxicillin, metronidazole, and quinolones in the smaller breeds. Then intestinal protectants, steroids. We have seen different types of steroids. We have seen immunosuppressive drugs. Immunosuppressive drugs can be added, and both the dose can be reduced. Drugs and diet modification. These are all the important things we should have to think about small intestinal disease. Then we are think about disease of the colon and rectum, history and clinical signs, overt signs of large bowel diarrhea, especially it's got tenesmus, hematochezia, staining, urgency to pass. These are all the normal clinical signs of colon and rectum. Acute and chronic, either chronic. If it can be static, it can be progressive. If it is got neoplasia, if it is cyclical, you think about IBD. Response to hypoallergenic diet, it is food hypersensitivity. If it is a roaming freely dog, then you should think about parasitic and infectious disease. Response to steroids, it is IBD. So what are the different diseases which causes tenesmus and dysphagia? Colorectal diseases and perineal and perianal diseases and miscellaneous. Constipation, colitis, and rectal strictures, neoplasia, polyps, foreign material, irritable bowel syndrome, anaphylactic neoplasias, urinary hernias, fistulas, diverticulars. So all these things you should be able to think about when it comes to colon and rectal diseases. When the animal is showing severe tenesmus and dysphagia, the owner will tell you that when the animal is passing loose motion, on careful examination, if you ask him, he will say it is sitting 5 times, 6 times in different places, staining and going small quantity. It is purely a problem of large bowel, especially colon and rectum. Physical examination, you have to examine prostate and genitourinary disease. Whenever there is going to be, a urethral stone, or when there's going to be enlarged prostate, is going to have difficulty in passing motion. So it will be staining, will be there. You will be thinking it is colonic or rectal disease. So you'll have to rule out prostate and genitourinary tract disease. Abdominal palpation, you can do for fecal impaction, interception, all these things you can do. Abdominal palpation. Rectal examination, you can see sometimes mass, sometimes bones, there can be pain, sometimes hair and mated matter in the rectum, diverticular stricture, perianal disease. All these things you can diagnose by rectal examination. Ontology, biochemistry, ultrasound, fecal examination, culture, cytology, diagnostic imaging, colonoscopy. So this is again the same thing where you see how we go about colorectal disease history. Then you have first see perianal disease, perineal disease or perianal disease, like for example hernia or anal disease. Then do physical examination. You'll find both of them. Laboratory analysis. If there is significant disease or minimal disease, therapeutic trial, parasitic therapy, dietary trial, positive response. If you don't have response, then you'll have to go for additional diagnostics. If the physical examination is again the dog has a lot of laboratory problems, then you can go in for additional diagnostics, fecal cytology, culture, imaging, colonoscopy, definitive diagnosis. And in case you don't have diagnosis, treat for motility disturbances like cysapride and like irritable bowel syndrome and see for the response. Acute colitis, self-limiting, causes diet and bacteria and their toxins and parasites. Motility modifiers like cysapride, antibiotics seldom used metronidazole, fiber supplements, hypoallergic diet. All these things can cure your acute colitis. Parasitic colitis, trichuris vulpis, fenbendazole for 3 days, trichomoniasis, metronidazole for 5 days. Bacterial colitis, Salmonella, Campylobacter, Clostridium, antibiotic if fever or bloody diarrhea is there. Of course, fungal colitis, you can go for itraconazole. Differential diagnosis for chronic colitis, parasitism, dietary, infection and neoplasia. Of course, final diagnosis histopathology for IBDs. Treatment novel protein, highly digestible carbohydrate, high fiber diet, sulfasalazine, misasalazine, steroids and antibiotics. So what are the doses of zalazopirins or oslacine or misasalazine, prednisolone, azathioprine? All those things are given in this table. You can follow this one for severe colitis. After ruling out helminthiasis and other parasites, you can go in for treating for chronic colitis. Irritable bowel syndrome, non-inflammatory large bowel diarrhea, chronic intermittent large bowel diarrhea. Rule out IBD, norm histopathology, dietary fiber, psyllium in the food. Interception, I told you, ileocolic or cecocolic, scanty bloody diarrhea, vomiting, abdominal pain, diagnosis, palpation, ultrasound. Constipation. This is another important topic which we should know thoroughly, how to overcome this problem by field practitioners. Common in dogs and cats, very common in cats than dogs. Prolonged cases of constipation can lead into megacolon, where the neuromotor disease happens and you'll have to go in for surgical options. Diagnosis, history, palpation and radiograph. Treatment, mild water enema, fiber supplementation, laxatives, lactulose, cysapride, ranitidine. We'll see what they are. So what are the etiology of constipations? It can be dietary, can be environmental, like obesity, hospitalization, change in routine, unsanitary living conditions, bad litter, so not cleaned litters, they will not pass motion. So all this is a very important thing in cats. Colonic obstructions, neuromuscular, megacolon, lumbosacral spinal cord disease, fluid electrolyte imbalances like hypokalemia, drug-induced anticholinergics like opiates, laxative abuse, all these things can cause severe constipation. So use of laxatives, this again we'll have to be very careful in choosing laxatives. A natural laxative which you can ask the owners to give, pumpkin, you got pumpkin, tinned pumpkin, you got pumpkin powders, or you can give a pumpkin, cooked pumpkin. Phycelium powder is available, phycelium can be added to the food. Wheat bran can be added to the food. All these things can be added to the food to improve the defecation. Bisacodyl is a stimulant. Small dogs and cats, 5 milligram per day can be used. And if it is a bigger dog, 10 milligram per day can be used. Bisacodyl, a stimulant laxative. Lactulose, excellent, 10 ml orally you can give. You can tailor the lactulose dose so that it doesn't have diarrhea. Cisapride, 0.1 to 1 milligram per kg body weight can be an excellent laxative effect and can have motility modifier. Dioctyl sodium succinate, DSS, 50 milligram capsule per day in cats and 1 to 4 capsules per day in dogs. Suppository, same dioctyl sodium sulfosuccinate is available. Suppositories, glycerin suppositories available. Bisacodyl suppositories available in human practice. They can be always used in the case of dogs. They are also available in pediatric tubes, which can be easily applied in case of pet animals. Enemas, again, very important to give enemas when there's going to be a severe, constipation. Constipation can be very acute and life-threatening sometimes. Warm water, 5 to 10 ml per kg body weight, after which you make the animal walk and exercise them. They might liquefy and it might defecate. Isotonic saline, 5 to 10 ml per kg body weight. Again, here also after giving 5 to 10 ml per kg body weight, make the animal walk, make them go on the routine place where they usually smell, because elimination habit in dogs is based on olfaction. Regular, place where they defecate, if they goes, it will provoke them to evacuate. Dioctyl sodium sulfosuccinate, 5 ml per cat as enemas can be given. Mineral oil can be given as enemas. Mineral oil can be given orally, but again you have to think about aspiration pneumonia, so better to give mineral oil as enema. Lactulose, 5 to 10 ml per kg body weight as enema can be given. Phosphate enemas can be given in dogs and it should be avoided in cats. It's contraindicated in cats. Disorders of perineum and anus, anal gland impaction, which all been seeing. You have a pair of anal glands in both 4 o'clock position and 7 o'clock position. You know how to remove them. Usually all veterinarians generally keep pressing from outside. That's not the way. You have to sedate them, cloud the finger. You have to use with the lubrication and gently compress the gland. Otherwise, it's very painful. Sometimes anal gland impaction itself can cause constipation. So painful. So general pressing by an attender is not a very good practice. It can sometimes anal gland abscess can be there, which causes severe impaction and things like that. Perineal hernia, you all know how to diagnose and surgical cure. Paraprostatic cyst, ultrasound is the best way because you have severe dystocia, painful defecation. But if you do ultrasound, you find beautiful paraprostatic cyst, and surgical option is the best. With this, I end my topic on small intestinal and large intestinal disease with special reference to colon and rectal disease. Any doubts, I may be more than happy to clarify.
One is, sir, what is the use of ivermectin in parvoenteritis?
See, it takes care of giardia.
Okay.
Which is an after effect of parvo. When it is immunocompromised, you get other parasites. So ivermectin is good. Not only this one, there can be other parasites also coming into the gut. Even as an adult animal or as a small puppy, there can be other helminthic parasites or giardiasis. So ivermectin is a good drug of choice. You can give when you should not give them in a debilitated dog. If the puppy is healthy, you can give.
Like
Otherwise, you will not give.
In parvovirus enteritis, if the puppy is having vomiting, so can we give it in an injectable form?
Ivermectin, yes. That's what I'm saying. You can give ivermectin, yeah.
Okay, and what is the dose rate you prescribe, sir?
Same 200 microgram per kg body weight.
200 microgram per kg body weight. Great, sir. Enema, which is used in human, the ready-made one, how safe it is for our pets?
Excellent. You can definitely use, but I just wanted to add, that you should come out with specific, modality to dispense enemas in veterinary medicine. Nobody has done so far. It can be a novel product because constipation is a very, very common problem both in dogs and cats. You can have a smaller than pediatric one. It will be much useful.
Okay. Why loperamide is contraindicated in infections?
So whenever there is a severe bacterial infection, the toxins are not let out. See, the enteritis or diarrhea is a form of expelling the toxins, and you bind them inside and they get absorbed. Toxin gets absorbed.
Yes. What is the significance of diagnosing prostatomegaly in small intestine diarrhea?
See, because if it is going to have, difficulty in passing motion, you may be thinking it is having a large bowel problem. So it might be a prostate problem. So if you treat prostate, then the problem is solved. The defecation become normal. It will not have tenesmus or large bowel diarrhea. So the classical clinical symptom of, prostatomegaly is ribbon-like feces because the prostate is compressing the up from above the intestines. I mean the colon. The fecal matter will be like a ribbon, flat.
Oh.
That is a clinical indication. But if it is going to have constipation and is going to have tenesmus because of severe involvement of prostate, whether it's going to be a prostatic hyperplasia or it's going to be a prostatic cyst, where it's going to be very big and compress the whole digestive tract, it can have severe tenesmus. So you have to rule out prostate in a case of large bowel diarrhea. Nothing to do with small bowel diarrhea.
Use of Oriprim in parvo.
What is that?
Oriprim.
What is that? I can't catch.
Muhammad Shafiq, you have to ask it again. Oriprim. I'm trying to recall what is Oriprim. Yeah, Oriprim. Oriprim
is what? Potentiated sulfur?
Pardon, sir. I don't know.
What is it asking? What is he? Is he telling me?
He's asking what is the use of Oriprim in this thing, parvovirus.
I don't know.
Cotrimazole. Oriprim are the cotrimazole tablets, I believe. Oriprim are cotrimazole tablets, I believe. He's asking.
No, definitely not give.
Sulfur with trimethoprim.
You should not give potentiated sulfur in case of paro and gastroenteritis. I told you the drug should be a 4-quadrant approach where it tackles gram-positive, gram-negative, anaerobic and aerobic organism. So the best things are potentiated amoxicillin, metronidazole, cephalosporin and quinolones. And if the animal is well hydrated, gentamicin is excellent. But only problem with gentamicin, you need to give twice daily and therefore owner compliance will not be there.
There is one question, sir. Can you please guide us quickly how to assess dehydration percentage in dogs and cats?
Hydration percentage, skin target test. If the skin target test holds for a long time, is 5%. If there's corneal moisture is not there, is 7%. If there's going to be only a pupil is not seen, it is 10%. This is how you see hydration percentage. It's purely physical. Moisture, corneal moisture, Then they are seeing a pupil or sclera and skin turgor test. These are things which are going for seeing hydration.
Okay. Sir, what is the SI affections, small intestinal affections in feline dysautonomia?
Dysautonomia is a motoric problem. Okay, so definitely there also you will have inflammatory bowel disease. You will have a systemic, small intestinal bacterial overgrowth. It's purely a neuromuscular disease, which is very rare. Dysautonomia in cats.
Okay. For which all antibiotics we have to use anti-ulcer drug along with it. Does Doxy need Pentop?
Huh?
Does Doxy need Pentop? I mean, he's asking
because Doxy causes severe esophagitis and ulcerations in the stomach. So definitely you have to give pantoprazole, and you have to go in for Swen also, sucralfate.
By the way, Oriheal Lifesciences manufacture both pantoprazole and doxycycline.
Oh, it's good. You have to give. Whenever you give doxycycline, you have to give.
Yes, sir. Both in injections also. IV injections also.
Yeah.
What should be the balanced choice in lack of blood transfusion facilities between maintaining perfusion and maintaining PCV in anemic patients going in bloody diarrhea?
So I told you, less than PCV or less than 15, you definitely have, even less than 20 is indicative. But since critical level is 15, less than PCV 15, you will have to go for blood transfusion, whole blood transfusion.
Okay. How to treat medicinally partial and complete ileocecal functional obstruction in dog?
Only laxatives, protectants, antibiotics. And you can try motility modifiers if it is not complete obstruction. If there's going to be a cecal inversion or cecal, carcinoma or anything like that, or if it's going to have intersusception, then it is contraindicated. Otherwise, you can go for motility modifiers. One, there is motion coming, but it still has got colitis, dystocia, and nematocysta is there. Then you can go for cisapride, and you can go in for mucosal protectants and antibiotics, these combination drugs.
Treatment of anal sac diseases.
Anal sac disease is mainly, you'll have to compress them under sedation and treat them with antibiotics and hot compress. And you can also remove them. Repeated otitis, you can remove anal sac. There's a correlation between, repeatedly having otitis and anal sac problems. So you can remove this one anal sac, then you have a cure for otitis also.
Wow, that's a new piece of addition knowledge. Yeah. Can we DDX HGE and Parvo from clinical signs?
Of course, I told you acute onset. If it is just yesterday normal, today is going to be when it is a hemorrhagic gastroenteritis. Okay. Otherwise, it's going to be a prolonged illness. Is going to be parvovirus enteritis. Nevertheless, the treatment for both seem to be the same. So you don't have to worry. So in case of hemorrhagic gastroenteritis, it's going to become all right the next day. In case of parvovirus enteritis, it may take 2-3 days more.
Yes, yes. Best antibiotic for Clostridium.
Clostridium, you can go in for same. I told you this 4-quadrant approach: cephalosporins, potentially amoxicillin, metronidazole, and your gentamicin.
Can we use Canglobe in feline parvo, sir?
Yeah, of course you can use. Yeah, you can use.
Okay. How significant, sir? Please, you carry on. Please.
It's very useful in case of this one felines than dogs, but dogs also definitely can use.
Okay. How significant neostigmine is the management of GI disease?
I have not tried with neostigmine, but maybe it's good for for motility modifiers.
Next question is best choice antibiotic in parvo. I think you have already given answer.
Yeah.
Why first give some warm salines and then warming to patient?
See, first thing when you're giving IV fluids, it should be warm to body temperature. First 2 hours warm, the body, the fluid should be warmed up, not the body. First, the fluid should be warmed to body temperature. You should not give from the refrigerator.
Yes, sir. Yes, sir.
Okay, should not give
Especially
ice
in
cold
winters
food.
also. In winters also, we do the same thing in North India. Because
Yes.
sometimes it's very chilling temperature.
Yes, so you have to warm the IV fluids, so there's no vasodilatation, and give IV fluid. After 2 hours or 2.5 hours of fluid therapy, more than 50% of the hydration is complete, then you'll have to warm the patient if it is hypothermic. Because, again, if you give before, it will have vasodilatation. So you'll have to warm them after giving IV fluids. After improving the vascular compartment, then you can give, you should warm up the patient so that it responds to your fluid resuscitation.
Sir, do you suggest an antiviral drug for parvo?
No. Filgrastim is okay. Human granulocyte stimulating factor.
Yes, filgrastim is the best thing.
Filgrastim
so
is good. Filgrastim is good. More good in felines. Good in dogs also. We are using.
So any dose rate you recommend?
No, it's not dose required. It's dependent on 1 or 2 injections. You can and see how it improves. The neutropenia should improve.
Sir, the rapid snap kits available for diagnosis CPV claiming to be ELISA based. How accurate and specific they are?
So it can be give false positive even for vaccine also. So my personal opinion is we don't require ELISA for parvo because anyway you're going to treat acute hemorrhagic gastroenteritis.
Yes. And the same treatment is given.
See, by seeing by diagnosing parvo, your line of treatment is not going to change. Your line of treatment is going to change based on how the patient is responding to your treatment. Whether it has got shock, whether it has got DIC, whether it has got hypovolemia. These are the things, or it's got hypokalemia, it's got hypoglycemia. These are the criteria. It's purely a medicinal subject, not a viral subject. Let it be anything. Let it be parvoviral enteritis, or let it be combination with corona, or let it be hemorrhagic gastroenteritis. Let it be anything. But what we are interested in hemodynamics and hypovolemia and your potassium, your glucose. This is what we are interested in seeing, and to revive the animal from shock. This is purely a critical care medicine rather than viral disease.
So there is a question, but I think we can answer it later on. Can you share routine trade names for below drugs like diphenxolate, azathioprine, budesonide, and chlorambucil?
I will put a H1 and send it to you.
Yeah, meropenem brand available in India, significant over regular antiemetics.
Yeah, meropenem is available now. Yeah, I've seen, we are using here.
Yes, it is available.
I know, it's available, yeah.
It's available.
It's excellent antiemetic for all CRTZ centers and hypothalamic induced vomiting. Meropenem is the best drug.
Sir, you have any exposure of this granisetron?
No.
Okay.
No, I have not used it.
This is also a wonderful drug right now.
Okay.
Yeah. At what time should we collect antibodies containing plasma from vaccinated dogs for parvovirus, and in what amount?
Your client would have brought it 3 months before as a puppy. Now it would have become about 20-25 kilos of Labrador Retriever. You can collect.
Okay.
The antibodies will be there.
Yes. Can we give doxy and this has already been done orally? Can we use steroids in case of food allergy?
Of course, you can use steroids.
Yes.
So because you don't know whether it's food allergy or food intolerance or whether it's food hypersensitivity, you can definitely use steroids if it is not responding to your hypoallergic diet. Your normal, first, don't jump immediately to steroids. So your steroid should be the last weapon. If your normal feeding, modification and your protected modification, all those drugs and all, you give antibiotics, all those things. If it doesn't respond, then you can go for steroids. Elimination diet. After that, you can go for steroids.
Sir, when to use tylosin antibiotics?
Which one?
Tylosin
Tylosin, whenever you want to use metronidazole, you can use tylosin.
How to diagnose ankylostoma in field condition?
Just only smear. And if you have a strawberry colored motion and you take a small thing and put it under the microscope, you find. Otherwise, deworm them. Simple. You get response immediately. No, you deworm them, and immediately after another 2 weeks again deworm them. Repeat that for another 3-4 times. You get complete cure.
Is there any role of vitamin K to arrest hemorrhage in intestinal diseases?
No. No, definitely not. Because what you find in intestinal disease hemorrhage is a primary hemostatic disorder. There is nothing to do with your ethams layer or vitamin K or calcium. Nothing to do with them.
Okay. Okay. Novel protein diet in vegetarian dogs in chronic diarrhea case.
So I won't say it is a novel hypoallergic diet, but the best diet for GI tract disease is cottage cheese and rice.
Cottage cheese and rice.
Yeah.
Okay, that's great. Sir, did you try Zulac, Intas, and Parvogard IL for diarrhea? It is useful?
No, I haven't. See, many things we are giving in addition to our regular treatment. No, so you cannot document and say this is very good because this. But definitely, nevertheless, you can. We are using it.
Okay. Can you please tell different antiemetics choice in different emesis etiology?
I will categorize and put it. No, last time I put the same thing. I'll put it in this one.
That will be shared soon.
Yeah.
Sir, what is the dose rate of I think you have already answered this question. Filgrastim in cats and dogs. Is doxycycline effective in case of panleukopenia?
Panleukopenia, no.
No. There is one last question. Sir, why are you against using hemostatics in parvoenteritis?
Because the pathogenesis is different, no. This is purely do with shock, septicemia, dick, and platelets. Nothing to do with the clotting factors. Right. Secondary hemostatic disorder only you have to use your calcium, your ethamsulate or your vitamin K for secondary hemostatic disorder. Primary hemostatic disorder is purely because of platelet reduction or abnormal platelets or platelet sequestration. Okay, only these conditions, only platelet abnormality alone you'll have to use. You find in case of parvovirus gastroenteritis. You don't get gastroenteritis in case of of course you might, supposing you have Decameron poisoning, rat poisoning, and you have enteritis, then you have to give vitamin K.
Yes. There
you have a factor problem.
Sir, in rat poisoning, any dose rate you recommend for vitamin K? Particular dose rate?
No, you have to give multiple times based on response. You have to keep giving every 3-4 times.
Right, sir. And any drug used for thrombocytopenia? Particular drug?
Thrombocytopenia only steroids, or you can go in for your anti-cancer drug which you use for TVT. What is that? Hey, my God! What do you use for Sven? No.
Vincristine.
Vincristine will increase immediately the platelets. You can go in for that. You can give steroids. You can give all this papaya extract. All these things will increase your platelets.
Okay. Causes of anal scooting in dogs and other than anal sacculitis?
So your foreign bodies mainly, and it can be your whipworm, then your foreign bodies like air balls, mated material like grass. All those things can cause. These are the main thing where you will have scooting. Of course, tapeworm.
So with this, we finish today's session. This was a wonderful session, sir. And still veterinarians are here on Sunday evening and they are eager to know each and everything about the small and large intestinal diseases. Thank you very much, sir. You have been always wonderful and you have immense knowledge about everything. And thank you for being here with us, sir.
Thank you, Dr. Sharma. Have a nice day.
Same to you, sir. Have
Hello.
a nice day and evening.
Anika,
And,
thank you so much.
yes, sir. Kanika is also saying thank you.
I
to
thought
sir.
I heard her voice.
Kanika?
Hello.
Yeah, please tell me.
Sir,
Yes,
have
sir.
a question.
Kanika is there. Kanika is there.
thank you so much, sir.
No, I thought I heard your voice, so I said thank you.
Okay. Thank
Somebody
you, sir.
else
Thank you very
will
much.
talk?
Pardon, sir?
Somebody else is trying to talk. I don't know. Somebody else's voice I heard.
No problem,
Yes,
sir.
sir.
No problem. Yeah,
How
sir,
far is
somebody-
in impacted colon? How far is enema helpful in impacted colon?
Yeah, you see, if it is not very bad, your impacted colon, it has to liquefy and come. You'll have to use different types of laxatives. You have to exercise them. You have to first rehydrate them, so that, because those things will emulsify those hard fecal contents. And if it's very bad, if it is very hard and it's going to be a megacolon, you can even sedate them and emulsify, break them with your hand. Okay, by palpation you can break them, but you'll have to sedate the dog. You cannot do like that. You'll have to sedate them and remove them. And if it is going to have a megacolon and motoric disturbances, then you'll have to go for surgery, resection of the colon.
Thank you very much, everyone. If you have any other question, you can directly reach us and we can answer it later on, because it has been already 6 o'clock. And Dr. Saab is also a very busy man. He has already spared a lot of time on Sunday busy evening. So I request you to post your queries directly to me or directly to Kanika, and we will help you out to get the right answers from Dr. Nambi. Thank you very much, everyone. You have been a great audience.
Sharma sir.
Thank-
Sharma sir.
Ji,
Sharma
sir.
sir. Sir, please can you upload the question and answer also, sir, in the recordings, please, if possible.
Definitely, sir. We are going. I think we are finding it more useful because questions
sir.
and answers are the right gist of the series. So
Yes,
we
sir.
will
Yes,
upload the question answer session also, sir.
Thank you, sir. Thank you.
Thank you. And just we request you to all our veterinarian brother and sisters. We need your support. So we will be looking forward for your kind support, sir. Thank you very much. Have a great Sunday evening. Bye bye.
Thank you. Yeah, bye.